All right. Let me, woo, woo, that's bright. Let me fix that. There we go. Okay, so maybe you guys can see me a little better. I didn't realize that was an issue at first. This is your last lecture for respiratory, and we're covering lung volumes and capacities, what those definitions are, what you need to commit to memory. So let's just kind of go through those really quickly. So you have the term expiratory reserve volume. This is amount that is expelled beyond the end of expiration. So if you exhale and right before you're ready to inhale, if you and push the air further out, that's your expiratory reserve volume. Now, just like with the expiratory reserve, if you inhale and get to the top of inhalation in a normal breath and you're ready to exhale, if you inhale beyond that, that's your inspiratory reserve. And your vital capacity is defined as the sum of both of those plus your tidal volume. You do have a thing called residual volume and minimal volume. So residual volume is the amount that remains in the lungs despite a max exhalation. So you've as far as you can go, and you can't go any deeper. There is still going to be a volume in there. If you've ever knocked the wind out of yourself and you're like, and you're trying to do that, you actually knocked not only your expiratory reserve out, but you knocked a little bit of your residual volume, and your body is having to fight to reinflate that sucker and get it back up where it needs to be. I've done that once in my life. I never want to do it again. It terrified me. I was a kid, and I ended up hitting a tree. I was riding my bike, and I got distracted anyway. I ran into the tree, and when I did, I hit my chest wall, and it shoved all the air out of my chest wall, and I had to fight to get the air back in, so I was freaking out. But that's residual volume. It's the amount that remains in the lungs after max exhalation. That's the amount of air we need to keep that alveoli open, the amount of air that's sitting in the bronchioles past exhalation. And then you have minimal volume, and that's the amount of air in the system after the pneumothorax. So here is what that looks like if you were to put it on a graph. This is what you would see. So you have your tidal volume. Let me get my little pointer here. So you got your tidal volume. Then you have that, remember you have that expiratory reserve. So right before you get ready to inhale, you exhale further. That's about 1,000. And then if you have the inspiratory reserve, you can actually get to 3,300 milliliters. So that's a big amount there. Your vital capacity does not include your residual volume or your minimal volume. It just includes the tidal volume plus that inspiratory and expiratory reserve. And then you have the residual volume, which is about 1,200, and that little bit of volume in there as the minimal volume. Your total lung capacity includes all of this. So that's how they figure this out. So just what is it that we breathe on a daily basis? Well, you would probably be surprised to know that nitrogen, which is an inert gas, makes up the most in terms of torr or pressure at sea level. So nitrogen, and they don't make this easy either. I don't know why they do this, but you need to know that it's 597 torr, but you also need to know how much percentage is. So they've got to make everything hard, but that's okay. So about the biggest chunk of what you breathe in is nitrogen. It's an inert gas, and actually what nitrogen does within our body is it keeps our hollow organs inflated. So that's how we manage to keep our small intestines slightly inflated, to keep them from collapsing on themselves. Same with our bladder and so forth. Now, oxygen is 159 torr, which we know for percentage-wise is about 20 to 21%. Your water is 3.7 torr, and your carbon dioxide is 0.3 torr. Now, if you added all that stuff together, it would come up to 760 torr. And again, this is at sea level. So as you rise, that's going to change. So as you rise, the density becomes it becomes less dense. You lose the density. So you still have the oxygen, but those molecules are further apart. It takes more effort if you're at Mount Everest to try to suck those molecules in and get them into your body. So that's why we look at that, and the air pressure changes and creates issues for us when we start seeing like high altitude pulmonary edema or high altitude cerebral edema is the result of this change in the density of the air pressure. And this is just another picture to show you how that would appear. And this is the percentages. So we mentioned that earlier. Your nitrogen is 78.6%, oxygen is 20.921, water is 0.5%, 0.5%, and then carbon dioxide is 0.04. Within the circulatory system, our oxygen should be 80 to 100. We already know our carbon dioxide at 35 to 45, and our bicarbonate at 22 to 26. And our blood pH be 7.35 to 7.45. Now we mentioned that ventilation is the mechanical process of bringing air into and out of the lungs. So respiration is about the gas exchange, bringing gases into and out of the lungs, the chemical gas exchange. So this kind of shows how your cells, here's your alveoli, you've brought this oxygen in, you've taken a nice big breath, that oxygen passes through that single cell, the single cells, and gets picked up here on the red blood cell with the hemoglobin, and it gets brought down to the cell, or right here to the cell. And here's your cellular perfusion. So the cell says, yep, I need some oxygen. It's going to offload it. Now remember, I told you there's oxygen that sits here in the plasma. That's what we're representing here. So that oxygen in the plasma is going to dissolve out, do its thing, get picked up. This is going to move off. It may get picked up too, or you may have some oxygen that ends up sitting here in the plasma to take the place of what was lost here. Now the cells are going to do their thing. They're going to spit out their gases. They're going to spit out the waste products, their poo, if you will, and it's going to pull that carbon dioxide into the bloodstream. It will also connect in here, and then it's going to bring it back up to the lungs and exhale it. So when it comes to respiration and how our body controls it, well, thank the Lord we have something that helps us with that. And you have some backup mechanisms included. So the respiratory rhythmicity centers are located in the medulla oblongata, and they really tell us when to inhale and when to exhale. We do have a backup mechanism, and that's in the pons. The pons contains two centers. One's called the apneustic, the other one is called the pneumotaxic. But the apneustic center is what helps promote the inhalation, whereas the pneumotaxic center inhibits inhalation. If you've ever had someone who's had a severe head injury and maybe they have my brain just stopped. They have the brain herniation, so you start to see herniation, and that pressure is being placed on the pons. That's when you start seeing that guppy breathing. If you've ever seen someone, it's the body panicking because it knows that something is messed up. It knows that they're in trouble and is trying desperately to survive. But our pons on a normal day can actually adjust rate and depth. It allows us to be able to talk and to sing if we are so inclined to do so. It's also what responds to us in emotional states or sensory stimuli. So it can help adjust the rate and depth of our breathing in order to make that happen. So we have the medulla oblongata, which has the rhythmicity centers that trigger that inhalation, exhalation. But the pons can influence it and create responses as necessary. In the event of trauma, you may see trauma, stroke, or brain herniation, you may see alterations in the breathing patterns. There are three very specific ones that are associated with trauma, stroke, or brain herniation. It starts with Shane Stokes, and it's almost like you have this inhale, exhale, inhale, exhale, inhale, exhale, inhale, exhale, and then it starts getting smaller again. That's your Shane Stokes, and then you have this period of apnea where it doesn't breathe at all. Biots is you have the same tidal volume. You have a typical tidal volume that's pretty regular, but you have these patterns or this disorganized pattern of apnea that gets thrown in there. Ataxia, they're all over the place. They may have a little tidal volume here, big tidal volume next, a little bit medium size, just real small, big. It's completely disorganized. So those are the types of abnormal breathing patterns that you will see in the case of trauma, stroke, or brain herniation. And yeah, you will need to know the names and how they appear because they will come up on tests. Now you do have some baroreceptor reflexes out there, specifically the Herring-Brewer reflex. This is during forced breathing, and it's part of that inhalation and deflation reflex. What the Herring-Brewer reflex does for us is it actually prevents us from either overexpanding or completely collapsing our lungs. So there's these little stretch receptors in there, and when the lung gets real full, it sends that stretch receptor, it triggers that medulla and says, okay, it's time for you to exhale, and it will relax. And then when the stretch receptor stops getting triggered, it sends that message, okay, we need to inhale again. So it's that little system, those baroreceptors, based on the amount of stretch, as when they're going to allow the exhalation to occur, or okay, we can go ahead and re-inhale again. So it's all about what it tells the medulla and the pons to do. We do have chemoreceptors. They respond to changes in pH and cerebral spinal fluid. Like I had said before, they primarily respond to carbon dioxide. The one thing I didn't mention in the past was in the event of a hypoxic patient. So if you recall, we had the little cat, and he is up there in the aortic arch and the baroreceptors, or not baroreceptors, I'm sorry, chemoreceptors up in the aortic arch, and he's got his little book, and he is marking down each and every single oxygen and carbon dioxide that come through. But in the aortic arch, what do you have more of? Do you have more oxygen or do you have more carbon dioxide? That's the blood going to the body, so we should have more oxygen. So it is not going to be interested in looking at oxygen because it knows there's a lot of it. It's going to pick the lazy route. It's going to look at the carbon dioxide. And it's going to go, okay. So we can count carbon dioxide a lot easier. So it's sitting here and it's like, all right, we got another one. Okay, we got another one. We're cool. Everything's doing good. What happens in your emphysema patients? Your emphysema patients or your COPD patients have gone with alterations in their oxygen levels long enough that the carbon dioxide levels have become higher in the aorta. And as a result, there's less oxygen. So guess what that chemoreceptor does? It switches and starts looking at oxygen. So it's like, oh, this is much easier to count now. I'm just going to stick with the oxygen because this guy has ruined his lungs. So I'm just going to count oxygen. But one day he has a really bad day and he's having a lot of trouble breathing. He's short of breath. In comes the good EMT and the good paramedic, and they put oxygen on him because that's what you should do, right? They're having trouble breathing. They have a pulse oximetry of 78%. And we're going to give him oxygen. We're going to put him on a non-rebreather. Well, all of a sudden that oxygen, he's up here. Remember, he's up here going, okay. And then all of a sudden he's like, oh my God, we're out of control because he's like marking all this oxygen. And he's like, holy crap. So what does he do? He sends that signal. He literally sends a signal to the brain. It goes, hey, we have a problem. I'm the chemoreceptor here, aortic arch. I'm looking and we have a problem. He is breathing too much. We have too much oxygen in the bloodstream. We need to do something. Make him slow down. So in your hypoxic drive patients, that too much oxygen will cause them to slow their breathing down because he realizes or that chemoreceptor believes in his heart of hearts, if he had one, that the patient is starting to they're losing their pH balance, and they're going to become very off balance. They're going to lose their hemostasis, and we don't want them to be in an unbalanced state. So it's going to drop their respiratory rate because it thinks, oh, we need to retain carbon dioxide. We need to retain it because we've got too much coming in the system. So if those are the hypoxic drive patients that start to slow their respiratory system down, you take them off the oxygen and their respiratory status will come back up. Or we hope it does. You hope you caught it in time. That is the hypoxic drive. You do have control within higher centers of the brain. The limbic system, which is that old reptilian brain, it kind of can get involved in the case of rage, eating, or sexual arousal. It can change or adjust your breathing pattern when it wants to. And we want to look at what disease pathology can do. So this is our first one. So we're going to look at the impact of disease pathology. So this is a person who has a deep vein thrombosis. What can happen if that deep vein thrombosis breaks loose and travels to the heart and into the lungs? If it falls into the lungs and it obscures or occludes one of these vessels that gets that oxygen, or is supposed to be there to pick up the oxygen, could they become O2 deficient? If you answered yes, you are correct. Now this is a special type of emboli. It's called a saddle emboli, and it's a blood clot that's so large it actually expands out and occludes both main branches leading in to the blood vessels of the lungs. This is immediate and instantaneous death. It has happened before. One of the common things that you see this happen with, it's not the only thing. Let me make that very clear. It's not the only thing. But one of the things that you will see this saddle emboli occur with is in your pregnancy patients. So the ones that have been pregnant, they've given birth, it's a day or two later, and they have massive cardiac arrest, and they don't know why. And when they do the pathology, they will find that saddle emboli. They've had a blood clot, and it has settled and saddled the pulmonary vessels. The other thing that can happen is a pneumothorax. So in this picture, of course, we see that the lung here is fully inflated. It's behaving like it should, but this one has been deflated because there's air that's escaping and it's entering this thoracic cavity, and it's forcing the this particular lung to get smaller. And this is what that tension pneumo looks like. So we know that if this is a stab wound injury, we can come in here with an occlusive dressing and close it up. Now, what do we have to do on occasion? Sometimes we have to burp it because sometimes when that stab wound comes in here and stabs, it may also stab the lung tissue. And when they take an inhalation, it's bringing air in, but what is that air doing? It's escaping here and still filling up the space. So occasionally you do have to burp that site. But if we don't fix it, you'll see trachea deviation. You can see how it's pushing that tissue across. It's pushing it to the unaffected side. You see that the trachea is getting switched. Look at the pressure it's placing on the heart and the inferior vena cava, so that can drop your cardiac output just like we saw with the bag valve mask. You can pinch it off. So we want to definitely fix those. I'm going to show you what that looks like in an x-ray. So to give you a little bit of perspective, you look, first thing you do is come down here and you're like, okay, that's cool. Looks like a good diaphragm to me. We look at the margins with our ribs. They look decent. Looks nothing big here. Do you see we've got the spine looks nice and straight, so that's kind of cool. We also see the heart, but wow, this looks like it's a little extended over here. This looks like it's pushed. And we don't see a whole lot. You should see a little bit of the heart over here. We don't see very much at all, just a little tiny swig of it. There's your aortic arch. Kind of looks like it's pushed over. And then when you start looking, you will see that you have tracheal deviation. Do you guys see this shift here? It looks like it's bowing. That's the trachea. That is the trachea. And then you're like, well, I'm still not sure. I don't know why you wouldn't be, but I'm still not sure. Do you see anything else in here that looks abnormal to you? Anything that looks strange? Now, I know you're probably like, well, I see all these little stringies. Those are called infiltrates. Don't pay attention to those. That's not important for right at this very moment. But you're going to see that you have a line that exists here that shouldn't be here. That's your lung. So this is your lung as it is collapsed. You can see that lung tissue has completely separated away. And you can even see it if you consider here. You should have this, see how you have a gray color, but it's not fully black? Look how blackened out this is. And that line, that shouldn't be there. That's how you know. That's how you know. Now you do have the simple pneumothorax. You have the tension pneumothorax. You have a hemothorax, and you have a hemopneumothorax because they have to make life hard, right? So you could very possibly have someone who has, let's go back to our emphysema patients. We've picked on them a lot tonight. Your emphysema patients are really expanded out and bloated. That tissue is stretched out as far as it can stretch. What if they took a huge coughing fit? What if they took a huge coughing fit? Could you see that stretched out tissue going pop and creating this big open spot? You may have a bleb. That's called a bleb, a ruptured bleb at that. That weak spot has collapsed or has popped, and it's allowed the lung to slightly collapse. That's a simple pneumothorax. You can have the tension pneumothorax, and that's when you see it start pinching off and it causing problems on the unaffected side. With the hemothorax, you won't have any jugular vein distension because there's nothing to pinch off. Remember, in the tension pneumothorax, it's pinching it off. Now, I don't have a straw with me. I wish I did. If you think about your blood vessel, your jugular veins as a vessel, or as a straw, and you pinch off a straw, all that fluid that's up here is going to back up just like you would if you tourniqueted for an IV. So that fluid backs up. You're going to see jugular vein distension as a result of that because it's pinched, because it's pushing to the unaffected side. But in a hemothorax, there's nothing to really push. It just starts filling up with blood. So you will not have jugular vein distension. So that's how you remember those two. And then in the pneumothorax, you're going to have both. Here's the thing. Anything where it's air, remember, if you plunk it, it's going to be hyper-resonant. It's going to have air in it, so it's going to be hyper-resonant. If you plunk over that area that has blood in it, it's going to be hypo-resonant. So you're going to have a dull thud. That's how you know the difference. So if you've got someone laying down, you may be able to identify it. If they're kind of in an upright position, you may be able to find it. If they're laying down, you're going to have trouble locating it. This is what it looks like on a chest x-ray. So in this event, you have the normal diaphragm, but this looks terrible, doesn't it? What are we looking at? Well, first and foremost, I see a line here that shouldn't exist. So we know we have a collapsed lung here, but we have blood that's filled up here. So that's what that would look like. Now, this can get mistaken sometimes, so keep an eye out here. You want to make sure that you're looking at this with the correct lens and not the wrong lens, because someone with pneumonia could potentially look like this, but they're not going to have this going on over here. So this is a hemopneumo. Now, in the case of a condition called chronic bronchitis, we had our emphysema patients earlier. They were pink puffers because they're bright pink because they have extra red blood cells. They are skinny and emaciated. On the flip side, you're going to have the chronic bronchitis. These are our blue bloaters. They are cyanotic in color, and they are overweight. They are obese, and they will have nasty, gunky lung sounds when they cough. What is going on in there in chronic bronchitis? Not only do they have some thickened muscle and they have some maybe some constriction, but they're going to have an increase in the amount of mucus, and that mucus and the damaged cilia actually cause it to be very difficult for them to get the gas exchange, because the mucus now takes up the space and doesn't allow for that gas exchange to occur. This is a picture of someone with chronic bronchitis. This is where you start to see those little infiltrates. You see those little stringies. That's where you're dealing with all the mucus. That's all the mucus you're seeing. Another point to make here in this particular picture is look how far out expanded this heart is. Look how close it is to the rib cage. This is someone with an enlarged heart. This is someone who is also experiencing probably some congestive heart failure. Now with pneumonia, you've got infection. It's not just the fluid that you see with bronchitis. This is an infection. So with pneumonia, you need to remember there's going to be a temperature. They're going to have a temperature, and that infection is going to settle in the lowest point. So let's take a look here. Remember, on this lobe, on this side, you're going to have, because this is the right side, you're going to have 3 lobes, correct? What you have here is this weird white area, and it's sitting in the middle lobe, and that's the infection. So that is a symptom of pneumonia. And remember, you can identify pneumonia if you remember from the patient assessment videos. You can identify pneumonia because it's going to have that. If you have them say E and you're listening with the stethoscope, it's going to sound like A. You're going to have that weird hypo-resonant sound if you thump over it. You're going to be able to tell the difference. All of those are just diagnostic methods to confirm your belief. All those little eggs you can put in that basket. Let's see. Oh, okay. And in the case we mentioned earlier about high altitude pulmonary edema. Well, because you're at a high altitude, it's theorized that the blood vessels constrict, causing an increased blood pressure in the lungs. And because it's increasing the amount of pressure in the lungs, where does fluid go? If it's got an open space, where's it going to go? If it's getting squeezed, it's going to go to the open space. So as a result, it's gonna leak into the alveolar sacs, and that's why they get the high altitude pulmonary edema. And this is just a good picture of that nasty fluid throughout the alveoli. And you can have different adventitious breath sounds. You know, the rails, they used to call rails in Ronchi, and it was whether you had these little popping sounds or whether you had blowing bubbles of milk, or they used to say take your hair up to your ear, and that little fine popping, that was your fine rails, and then your Ronchi was the blowing bubbles of milk. So they've kind of taken those terms, you may or may not see them, they've taken those terms and combined them to call them all crackles. You either have fine crackles, which are the rails, or you have the thick, nasty, junky crackles, which are your Ronchi. And then the wheezing, I love this picture because it really does a good job of explaining what we talked about before with asthma. And remember, we looked at that shark fin appearance on the COPD patient, on the capnography, not COPD, but well, yeah, COPD, but more specifically asthma. So if they're having an asthma attack and the bronchioles constrict down, then the air is having to squeeze around that obstruction, and as a result you get that little wheezy musical sound. So National Registry says it sounds musical. And that is all we have for this lecture today. If you have any questions, please write them down. Let's discuss them in class. Otherwise, we will see you this week.